our third cohort of 3. So this is going to be the last cohort that we have as part of this project. It's been a 3-year project that we've had with HRSA, and we've had so many wonderful experiences with this program over the last 1.5 years, almost 2 years. It'll be 2 years in August, and we've learned so much. And we're so excited to have our last cohort, and we hope that you'll all apply, and we hope that you'll all be part of this last cohort to learn how to screen for adverse childhood experiences in a pediatric setting. So very excited to have you all here. So excited to tell you all about this program. And so today I just wanted to give you a sense of who's with you. My name is Molly Peterson. I am a senior program manager at the Center for Youth Wellness, which is a program of Safe and Sound. And I'm also one of the quality improvement coaches as part of this project, and I do a lot of the project management as well. And I'm here today with, like I said, my colleague Aldina from the New Jersey chapter of the American Academy of Pediatrics. Aldina, do you want to just say briefly your title?
Sure. Hi, everyone. Aldina Havdi. I'm a senior program director at the New Jersey chapter of the American Academy of Pediatrics. We are one of 66 chapters throughout the country. And our home base, our parent chapter is our parent organization is the American Academy of Pediatrics, and that's located in Illinois. So we are really happy to be here today to tell you a little bit more about this project.
Thanks. I am part of the Center for Youth Wellness, which was founded by Dr. Nadine Burke-Harris, who went on to be California's first Surgeon General, and really sort of started a lot of the discussions around the adverse childhood experiences and screening in a pediatric setting. So very excited to be here today with you. This project, like I said, we are funded by the Health Resources and Services Administration, HRSA, and this is all part of a project that we will send to Congress. We actually have a congressional report coming up in August, and so this is part of this report that will go to Congress and will inform some guidelines around screening in the pediatric setting. So that is our acknowledgements. Today's speakers have no disclosures or conflicts of interest. So webinar logistics for today, you are all muted. If you do have any questions, you can put them in the Q&A or in the chat. There are people monitoring both of those. So they will let us know if you have questions. We also have a question section at the end. So if you want to wait, we can wait and answer your question then. Any questions that we don't get answered today, we will make sure that we write down and that we send out as part of our follow-up email. You'll see we have a website for this project, njaap.org/TASIE, TASIE. So a lot of the information that you'll see today will be posted on that website later. Aldina, did you want to say something?
Yeah, just really quick as well. And as you are taking a peek at the Q&A, if you are able to share with us your name and what state you're from, that I think would be really helpful for us to just kind of get an idea as to who's on the call. That would be great. Thank you.
Yeah. Yeah, and I mentioned the Q&A and the chat feature, so you please utilize those and obviously remain professional, but we know you will. So I know one of the first questions we'll get is this being recorded and can we see it later? And yes, absolutely. So you probably got a notification already that this is being recorded right now. And we will post it about a week from now we will send it out as an email to anyone who's registered. So even if you had colleagues or other people were not able to attend, we will send this out to everyone who registered for the webinar. And then we will also post it on the njaap.org/TASIE website. So you'll have both the slides and the recording of this entire webinar there. And if you have any other questions, you can let us know. Our agenda for today, we'll go over the vision and aims for this project. We will talk a little bit about foundational ACEs science, just so you have a background on what we're trying to do here. And then I will hand it over to Aldina, and she will go over what it's like to be a practice site, our objectives, our benefits, our activities, She'll go over what is a Project Echo, what is the, what kind of quality improvement activities do we take on as part of this project. And then we'll talk about your eligibility and the application process. And then we'll do Q&A, like I said, at the end. Great. So our vision for this project is that all primary care and pediatricians and other primary care pediatric serving clinicians implement universal screening for adverse childhood experiences, also known as ACEs, and routinely use an understanding of ACEs and toxic stress to enhance the quality of patient care and health outcomes. So this is our faculty for this project. Wanted to give you a sense of who's working on this. Myself and Aldina have already introduced ourselves. We also have Carissa Luckett, who is one of our co-principal investigators. She is a senior director at the Center for Youth Wellness. We also have Stephanie Pinney, who is also one of the QI coaches and a program manager at the New Jersey chapter of the American Academy of Pediatrics. Dr. Stephen Carries, who is a doctor at a child abuse pediatrician at Hackensack Meridian Health. He is with Carissa, he is our co-principal investigator on this project. We have Ruth Gubernick, who is also a QI coach and is an independent contractor but has done lots and lots and lots of QI work and has great insights into doing a QI project. This whole project is set up as a quality improvement project. So you'll hear me say that a lot. And Ruth has a lot of background on that. Dr. Alonzo Patterson is a pediatrician at Pri-Med Health, and he was one of the, he was a practice site from one of our original cohorts. Even before we had the TASIE project, the Center for Youth Wellness was doing a very similar project, and he was in one of those cohorts. And so we've known him for a long time. And he's been doing this work in ACEs, throughout his career, but now we get to name it and talk about it. And he has some really great insights into the work that he's been doing. He often sees the children of people that he saw as when they were children. So he just has so much background in this and has some great insights. And then Deepa is also the director of early childhood initiatives at the SPARN Parent Advocacy Network. And she is a really great person to have a parent perspective on all of this. So this is kind of like the patient perspective on, we have a couple of pediatricians on here, nurses, so social workers. So she really represents that patient side of everything that we're doing, and what does it look like to be, screened, and what does it look like to discuss ACEs from a parent perspective, from a patient perspective. So it's really wonderful to have all of these wonderful people as part of our faculty, lots of different great backgrounds and interests, and has been a wonderful team to work with over the last 2 years. And then I wanted to introduce our administrative staff, because everyone knows that we can't do these projects without someone in the background, and multiple people sometimes in the background. So Lydia is here. She is doing all of our IT assistance with this webinar. Thank you so much, Lydia. And Camilla is also here, and she does an amazing job in the background, making sure everything goes smoothly with this project. So thank you to both of you. All right, this is the aims for the project. So we are attempting to study how primary care settings can best screen and provide care to children impacted by ACEs. So we are really trying to understand, what does it look like to screen for ACEs in a primary care setting and provide in-office interventions for those who are impacted by ACEs. And as part of that, as part of all of that learning, then we will produce a scalable model that can help pediatric providers integrate screening with strengths-based trauma-informed interventions in primary care settings. And so really, one of the things that you'll hear us say is we're looking for lots of different types of pediatric settings. So we've had large academic medical centers, we've had small one provider offices in different places around the country, because what we are looking for is to create that model that we can then produce for any type of pediatric setting, may, you know, again, like with all the different ones that I talked about, so that, you know, anyone can really take what they need from this model and use it in their own office. We've had a great run so far. We've had lots of different types of organizations. It's been wonderful. So with that, I will go a little bit into ACEs science. This is sort of our big overview. So adverse childhood experiences, or ACEs, were coined by Onda and Folletti in 1998 through the Kaiser study. So this was something that they did after they were working with obese patients, and we're realizing that so many of their patients would put them on diets, they would lose all this weight, and then they would gain it all back. And so they kind of kept looking at, okay, well, it's not just the physical, it's not just what they're doing, how much they're exercising, it's it's something else. And this was kind of where they eventually went, which is a lot of the people who lost the weight and then gained it back had trauma in their background. And so as part of to study that, then they created this Kaiser study in 1998 that was, you know, that did a lot of work in finding out that trauma can really affect you, not only mentally, but physically later in life, especially if you have trauma in your childhood. So especially if you have these traumatic experiences before the age of 18 and you do not have any buffering caregiving as part of your childhood. So I will talk about, there are sort of these 10 what we call core ACEs, and the only reason these are sort of the core ACEs is because these are the ones that have been studied the most. It is not to say that these are the only ones that could ever exist, or that things that could happen in your life that could create a traumatic reaction in your body. But these are sort of the 10, what we call a 10 core. So it's they're categorized into 3 categories: abuse, physical, emotional, and sexual; neglect, physical or emotional neglect; household instability, which is including mental illness in the family, an incarcerated relative, any substance abuse, excuse me. We say mother treated violently, it's really any partner treated violently in house. And then the original study used divorce. Now we sort of say separation from a parent. So if there was a parent, if there's an intact unit and that unit is sort of separated and one of the parents is not there as much, that can create some trauma in the child. And then these are sort of some of the other ones that we have also studied: community or school violence, racism, homelessness, food instability, separation from a family due to foster care or immigration and deportation, a caregiver's serious physical illness, and a caregiver death. So, and then together we kind of talk about, this is the pair of ACEs. So on top are all the sort of ones that you see, and then the ones at the bottom are really part of the community environment. So poverty, discrimination, lack of opportunity. So again, all of these can create trauma in a child's life, especially if they do not have a caregiver, a buffering caregiver. They can have some physical effects later on in life. So ACEs in the top 10 causes of death. So this is where I think the heart or the crux of ACEs is that we knew, and we still know, that all of these things can cause mental symptoms, psychological symptoms later in life. I think one of the things that we have really come to know over the last 10 years or so is that they can also cause really physical problems. And that's where the pediatricians and the doctors can really come in and help and think about how, if they're seeing their patients with lots of physical symptoms, that they can think about, okay, it may not just be the physical things that they're doing. It may be something else that's going on that maybe happened 20 years ago, but is now affecting them now. And that's, really one of the things that Dr. Burke-Harris thought about and really saw in her practice, is that she saw these kids that would come in who would have physical symptoms over and over, and she wouldn't, you know, and she would take all of her medical background and think about all the things that she could do, and those things weren't helping. And so then eventually she got to, okay, these kids are going through trauma, and that's what's really causing some of these physical symptoms, not necessarily just, you know, the physical things that are going on in their body. So these are sort of this is paints a really good picture of how physical symptoms can manifest when you have trauma. So for those people who have 4 or more ACEs in their childhood, the likelihood of dying by some of these top 10 causes of death go up, right? And so for, you know, example, chronic lower respiratory disease, those who have 4 or more ACEs are 3 times more likely to die of chronic lower respiratory disease, 2 times more likely to die of stroke, and then of course, and 11 times more likely to die of Alzheimer's, and then almost 40 times more likely to die of suicide. So again, these are kind of really concrete ways that we can see how this trauma affects people later in life when they've had trauma in their childhood and they don't have a buffering caregiver. So without intervention, there can be a 20-year difference in life expectancy for those who have 4 or more ACEs. We also know that ACEs are common. About 2 out of 3 adults have had at least 1 ACE. And so we know that these exist in all backgrounds. They disproportionately affect those in particular groups like women, people of color, people, LGBTQ plus populations, but we do know in general they are common throughout all populations. So one of the ways that ACEs can manifest itself is through the idea of toxic stress. So toxic stress is, this is sort of the definition by the National Academy of Sciences, Engineering, and Medicine. It's really, this is a better picture of it. So if they do not have protective factors or predisposed, or if they do have predisposed vulnerability, then they can have sort of chronic dysregulation. So toxic stress affects the neuroendocrine and immune systems. And when we say toxic stress, you know, there's sort of, we talk about like you can have tolerable stress, which is you take a test. And then you can have higher levels of stress, like a relative dies, maybe not your primary relative, like your parent, but a grandparent dies. And that's your system gets dysregulated, but then it comes back down. Toxic stress is really chronic. It's really every day. You are just constantly having this dysregulation of your nervous system. Your nervous system is just always activated. And with that constant activation, it can really help. It can affect your endocrine system, your neurological system, and your immune system. And then it can be epigenetic. So we know that it can be passed down from generation to generation. So one of the things that we do say about toxic stress is that it's not your destiny. If you had ACEs as a child, it does not mean that you are destined to then have terrible physical health outcomes later in life. There are lots of things that we can do to help both children and adults with handling some of the effects of the adverse childhood experiences that person has gone through. So we can see like the negative experiences on one side and the positive supports on the other. So if we continue to put those positive supports on, then we can sort of outweigh the negative experiences. And this is why we advocate for, really early intervention and screening in a childhood setting, because, the earlier that we can understand that there's something going on with this family, the more support we can provide that family, and the less likely there is of a negative outcome later in life. Again, that's not to say that you can't help somebody who's an adult who has had childhood experiences, absolutely, but that's really why we advocate for this early childhood intervention. And these are some of the things that we talk about when we talk about, we call them the domains of wellness. These are the ways that you can help somebody who has experienced adverse childhood experiences. Supportive relationships, again, buffering relationships, sleeping well, eating, using movement, mindfulness, spending time in nature, and supporting mental health. And then finally, this is, if you saw the pair of ACEs tree, previously those were sort of all of the negative things that can happen in a community that can affect an individual. This is the adverse to that, or let's say the better, the hope part of that. So these are all the positive experiences and positive things that community can provide children and families and everyone to really buffer some of those negative experiences that a child or an individual might have. Right, so that is my brief discussion of adverse childhood experiences. And I want to, and then I will hand it over to Altina.
Thanks so much, Molly. So I'm going to talk to you next about what is required, what is being a part of this work look like, just so you have a good understanding. And again, we'll have time at the end for questions to kind of go through some things. So this is really a demonstration site, right? This was organized by HRSA. It's a grant from HRSA that allows us to do this work. And really, it is the work of a partnership between both the Center for Youth Wellness and the New Jersey chapter of the AAP. And as part of that partnership, we like to bring together QI coaches to really work with you all directly, with you and your teams, to help create a plan to help you start screening and help you overcome barriers as you encounter them. So this is not a one-person job. This is something that is required of a partnership. And so far, we have had 2 cohorts of practices participate in this project. 17 completed the first cohort and 13 completed the second cohort. And you can see kind of the different states there. On the next slide, just to make it easier to see here, all of the states that we've worked with so far. And of course, we'd love to start coloring in this map a bit more. And in particular, we are looking for practices in Pennsylvania, West Virginia, Delaware, Maryland, Washington, D.C., and New Jersey. But we are open to receiving applications from anyone who is interested in this work as well. Next slide. So these are the 3 objectives of this project. So the first you see is to identify and learn how to overcome common barriers in screening for ACEs and providing evidence-based interventions. And we do this by providing you with tailored content, coaching, collaboration, supporting, and peer-to-peer learning. The second objective is really to facilitate opportunities to learn each other's unique journeys to screening and post-screening interventions. So we really want to understand how these learnings can be translated into strategies for similar practices. And the final objective is really to increase the number and the diversity of clinics or pediatric practices that are screening for ACEs and really provide those evidence-based interventions for children and adolescents who have experienced ACEs. Next slide. So why should you participate in this project? Well, obviously you all are interested, right? Because you're joining this session, but implementing any sort of new protocol, if it's an interest of yours, doing it alone is a little bit of a challenge, right? It's like pushing a giant rock up a hill. So really anytime you're trying to implement something that's that might be a little bit challenging, that's going to require a team effort. And implementing ACEs screening is one of those. It can be a complex process. This is really an opportunity for you all to partner with peers who are also interested in this topic and then learn from the experts in the field. And through the project, you will have access to expert coaches, a bunch of training materials and educational handouts in many languages, and operational guidance as to how to get this working within your practice. We're also going to be sharing aggregate results from this project in the U.S. Congress report to inform national guidelines around ACEs screening. So I think that's pretty exciting as well. There are also a lot of other benefits to participating in this project. So selected practices will receive $15,000 as a stipend, 25 Part 4 maintenance of certification points, 13 CME MOC points, and also access to all of your data in real time, as well as ongoing technical assistance and support, again, from the QI coaches and those who are experts in the field of ACEs screening. So to begin, you'll need to identify a team of at least 3 staff to participate in this project. This is really important. This should include your team lead or pediatric champion at your practice site, a data lead, and an administrative lead. And 2 of these team members should be asked or should be tasked with submitting data. All participating pediatricians will be required to complete a pre and post participation survey and monthly echo session evaluations. The echo session evaluations are really for those who are interested in receiving CME MOC2. You'll also participate in onboarding workshop, which is an hour, and a 2-hour ACES training workshop, as well as 8 monthly echo sessions. All participating practices will utilize either the identified or de-identified version of the Pearl screening tools to screen a target population of your choosing. You'll also submit case presentations to allow for peers and experts to weigh in about a particular family you're working with. You'll also participate in monthly coaching calls and in regular office hours for additional support as you need. And finally, we'll ask you to recruit parents and caregivers and adolescents to complete satisfaction surveys at the end of the project. And for that, they will receive compensation. They will receive a gift card. So your implementation team will include, as we said, a pediatric champion or team lead. This person is really going to serve as the primary contact for the project. The data lead will really be a member of your IT or a change management team member who can support any kind of EHR builds that are needed. And they can also assist in gathering and reporting data as needed. The administrative lead is really that practice manager or nurse manager or whoever you designate to ensure that the team has adequate time to fully participate in the project. And each of these roles, you'll see at the bottom here, it's really important that each of these is a separate person who has agreed to participate in the TASIE project, because we really do believe this is an all-team sport. Everyone should be involved in the practice. It would be difficult to do this project if you don't have the support of other team members. And of course, we always welcome the participation from other team members, including some of the folks noted on this slide. Again, it's a team sport. The more people from the practice that are involved, the better the outcome and the easier it will be to do this work. So there are also a few post activities, including participation in a focus group at the end of the project. There is also a post participation survey that we mentioned earlier that will really help us to know what you learned from working on the project. And finally, we offer all of our cohorts to participate in a quarterly educational echo. It's not required, but I think it has been beneficial to all who have participated so far. It really is just an extension of the work that you're doing on the project, and it allows you to continue learning and collaborating with your peers who have either just finished the project. Actually, in this case, it'll be people who are the cohort 2 who have just finished the project, or cohort 1 who finished a while back, but they are interested in still becoming involved. And we do have quite a few folks who join those sessions. So we've mentioned ECHO a few times already, and I'm guessing most of you know what ECHO is, but just wanted to kind of go over that with you. This ECHO stands for Extension for Community Healthcare Outcomes. It was designed really to encourage learning with peers and experts through a virtual mechanism. Of course, we use Zoom and more engaging sort of environments. Similar to the concept of grand rounds, the ECHO model has been well established in the literature. Next slide. So the ECHO sessions will be 75 minutes on the second Tuesday of each month. The structure is typically the same each time, though at times the order of things will change based on the session and the speaker. Typically, it begins with a welcome and introduction, a review of aggregate data, and then they go into case presentations and discussions, a lecture, and questions and answers, and then we kind of close out the session. I wanted to note that this project has been reviewed by New Jersey's Hackensack Meridian Health and has been determined that the activities of this project do not meet the definition of research involving human subjects, and therefore no IRB review is required. If you are in need of paperwork to share that with your practice team, we're happy to send that waiver letter as requested. So here's the timeline for the project. We're going to launch our virtual orientation and ACES training in September and begin the echo sessions in October and go through May. The end of the project, you're going to be asked to participate in a focus group so that we can continue to learn from you. So now I want to talk about eligibility and application process now that you've learned a little bit more about the requirements and benefits of the project. So eligibility for participating in this project is pretty simple. You have to be interested in integrating ACEs screening and intervention into your practice, but you can't already be doing it routinely. You have to have the resources either within or outside of your practice to be able to provide mental and behavioral and social services to those who need it. Again, this could be internal in your practice or external connections to community resources. You also have to have the capacity to start a program like this. We do, as you can see, we do ask for a lot. We will ask for reporting that will potentially require some tweaks to your EHR. You will need to commit to create a reporting system to collect and disseminate your screening data as well. And you'll also need to have the capacity to use web-based meeting services. I think most of us do at this point. And you'll have to commit to at least one member of your team attending the orientation, the ACES 101, and all 8 echo sessions. You will need to adhere to the project timeline that we set forth in the agreement that we would sign with you, and provide an adequate administrative support to fully participate in all aspects of the project. You would also need to agree to fully utilize the QI coaching that's provided and the technical assistance that we provide to you. And finally, we'll need you to consent for us to publish findings on this work, which would be outlined in your contract. So here's the application timeline for this project. The application will be available for you to start completing on June 8th. It will be due by July 21st at 5 p.m. Pacific, and we will notify all practices by August 18th. The application, again, is going to be available on June 8th. We will email everyone who signed up for this webinar when it is available. Interested practices can find the application online on our website, and I believe Lydia popped that into the chat. And I think now is time for questions. Looks like we have plenty of time for questions, which is great.
Yeah, and I just wanted to mention about the application itself. So the application is available via SurveyMonkey. If you do want a readout of the questions that might be easier, you can email any of us and we can send that to you. I know some people like to have them ahead of time so they can get their answers ready before popping them into SurveyMonkey, although I do know that SurveyMonkey won't time out on you. So it seems like if you just kept it open, you would have time to put all those questions in, but I've done plenty of applications like this, we all have, and I know sometimes those systems can be tricky. So just wanted to let you know that that's available. So let's see. It looks like there's a couple, is there a specific time of day? Yes, so we have sort of set up the sessions for 10 a.m. Pacific, 1 p.m. Eastern. When we started this project, I will just tell you that we just sort of did an extensive review of like what time would work for everyone. And it's just when you have a national program like this, it's hard to find a time that's going to work for every time zone. So that's kind of what we landed on. And so far it's worked for the other 2 cohorts. If you do need to, all of them are recorded. So if you can't make it that day, then you can watch it later. So that's just kind of what we've landed on. I think that's in the chat too. So thanks for adding that stuff. Let's see, someone asked if they can, if it would be possible to attend the echo sessions, even if not accepted. Elizabeth, why don't you email myself and we can answer that question. Let's see. How extensive are the EHR builds? So it's really, I don't know, Aldina, if you feel like you have a good answer for this, I can kind of start and then, so the EHR builds are not, we don't require you to go in and redo your EHR, but it's really, when you'll see the data that we ask you for. So we're going to ask for particular parts of the data, and in a lot of cases, it's easier to record that in the EHR and then add it to what's called KIDA, or the quality improvement data aggregator. And so that's why in a lot of cases, the EHR it could take a long time to sort of get those extra fields into your EHR, just depending on, I know different practices have different ways of doing that. So it may just be a few fields, but that's kind of what we asked for. Do you feel like that answered?
I think that was perfect. I mean, really, it all depends. I mean, I know it's a terrible answer, but it really does all depend on your EHR and kind of, it really does all depend. But we do have a lot of examples, right? So I think we try to work with you as much as humanly possible to try and assist with that.
The next question: how large is each cohort? So we're around 15. Is what we're looking for. So kind of, I think we cap it at about 15. Last time we accepted 14. So about how big. Open to family medicine, absolutely, for sure. Please don't think that this, especially if you see kids, sure, you can apply. If we are accepted, how soon is a report needed in relation to the EHR build? So not for a little while. So we will send out applications in acceptances in August, and we do our first, we don't do our first data until November. And we will help you through a lot of that. So there are a lot of, we'll go through in the orientation, what it is like, what data you're going to be requested to provide. And then we'll have sessions on how to enter that data into KIDA. We have a spreadsheet that you can enter data in that helps you enter it into KIDA. There's a lot of support for all that, but you do have some time. And there's a lot of people here that are willing to support you. Let's see. So what type of IT changes or issues might be needed? I don't know about IT. I mean, for EHR builds.
Steph, did you want to answer that live? I didn't know who clicked that. So hi, Deb. It's nice to see you on here. Deb is a physician that we work with in New Jersey, and she is also participating in another project with us on integrated care for kids. So that's really exciting to see you there. I think given everything that you're doing with integrated care for kids project, I think this is, that's part of that work as well. And I know not all docs have started that work, so we'd be happy to work with you on that. I think it all depends on the HR system that you have, and I'm blanking on what you actually have, but we'd be happy to work with you on that. Any other questions, Molly, that I didn't see?
I don't think so.
Exactly.
Yeah.
Thank you, Ruth. Yeah, I think because we have 4 QI coaches to work with, 3 to 4 groups of practices, I think that makes a big difference, because those coaches also meet together to kind of share and talk through strategies to kind of work with the practices as well. So I think, to me, the biggest, if you want to take one thing away from this presentation today, it's this project. It's really important to have a team of people working with you on this project. If you are trying to do it on your own, it's going to be hard. You definitely need to have a team of a practice team working with you. Doing this as a one single pediatrician would be, I would say, difficult.
Yeah, absolutely. That's why we're asking for somebody either on the IT team or on however it's sort of worked out in your office. So whoever does those like EHR builds or can create the reports or things like that, that's what we ask that person to be part of this team so that they can, you don't have to kind of convince them last minute to get this done. They're sort of part of it from the beginning and they can help. Steph, did you want to add? Steph is our data person. She's the one that does a lot of support of people who need help with their data. So I want Steph to weigh in here too.
Yeah, I was just going to say, you know, some of the practices weren't able to get the EHR build in right away when we started the project. So in the meantime, while you're working on it, we do have an Excel worksheet where you can plug in data, and most practices are picking a small population to start with. So it might be like 3, 4, and 5-year-olds that you're screening for their well visit. So again, it varies based on the practice and how many providers are participating, but you might have, you know, anywhere from 10 to 90 patients that you're collecting data for that month. And then the questions that we're typically asking for KEDA are basic demographics, and it's all aggregate. Basic demographics, and then whether they were screened, and then what the outcome was as far as the risk level. So if you have questions about what data we're looking for, I can send you, you know, a summary of the questions that we have, just so you have an idea of what we would be looking for. But again, if you don't have the ability to build the EHR in, you know, a couple months, that's understandable. Some practices have pulled the reports from the EHR system that they have for the worksheets, and some practices have just filled out the Excel worksheets as they went, and they just found that easier because the questions that KEDA is looking for might not match up exactly with the way their EHR prints reports. So I hope that makes sense, but if you have any questions, you can always email me. I'll put my my email in the chat also.
And we will have an extensive orientation about how to use KEDA and all of that. So, so no worries there.
Yeah, and I feel like there's some anxiety around the data. So yeah, I mean, Steph has talked through it, but we're not gonna, we are here to help you. This is not sort of a like, either you get the data in or you failed. Like, no. This is the whole point, is that we're here to walk you through all of these steps, because this is what we would, if you were to take this project on, or if we were to recommend this to a pediatric site or a family practice site later on, we want to have understand, like, what are the barriers? Data collection is a huge barrier, right? So how do we provide guidelines to that data collection that makes it easy for any practice to take that on? We don't want to make it a burden. We don't want to make it difficult for everyone. So that's, again, we're here for you to help you get through this and to help you get the data. So. And yes, so sorry, yes, the June 8th is when the application will be available. We're doing this about a week ahead of time, just so people have a sense of and can think about, does this make sense for our practice? Do we want to, take the time to do this? So you get about a week, and then the application will be available, and we will email that out to everyone who signed up for this webinar, as well as we'll send it out through different channels. So if you follow social media, I would follow NJAP on social media, LinkedIn, we'll send it out that way as well. And so you'll see it when it comes out. And the due date for the application, I think somebody answered that in the chat, but I'll say it out loud, is July 21st. And since at least one person on this team is on the West Coast, I'm in California, we gave you till 5 Pacific, so we give you East Coasters a few extra hours. But actually, please don't be doing an application at 8 p.m. on a Friday. But we do give you those extra hours if you need them. And of course, if you have any questions about the application itself, you can email any of us and we can respond. Right. Got through that pretty quickly.
Yeah.
Anything else, Steph or Aldina, you all want to add? This is, yeah, I'll let you.
No, I mean, I would just say, if you, it's a lot of information to digest in a small time, because it's a 9-month QI project. So there's a lot of factors that we go over in this informational webinar and when we start the orientation. So if you process it over the next couple of days, over the next week or two, feel free to reach out. We're happy to field any questions, or even if you want to set up a call just to kind of talk about your practice and just kind of brainstorm, is this a good fit for you? Feel free to reach out. We're happy to talk to you about it and answer questions.
And you know, I know the New Jersey team has been doing this for a while, and this is my 5th cohort. This will be my 5th cohort, walking practices 2 through setting up an ACEs project. So we've seen a lot of it. We've seen, you know, if you think that you have a lot of barriers to screening and you don't want to apply because of that, feel free to reach out to any of us, and we can talk you through all the things that we've seen in previous cohorts and previous practices who have had who have faced some barriers. We can talk about what we've seen to that they've used to overcome those barriers, or to get through maybe some difficulties that you can see. So yeah, we're here.
Absolutely. And I will say, like, our hub faculty is very diverse in terms of their expertise. I mean, Dr. Steve Carey's, he's a child abuse pediatrician. Steph, you have you can explain what your background is. You have a lot of experience in the trauma space, and she went through a training. I don't know, Steph, if you want to kind of share a little bit about yourself as well.
Yeah, so I'm a licensed clinical social worker and licensed clinical alcohol and drug counselor in New Jersey. So I've worked in direct care for about 14 years before coming to program management, outpatient, inpatient, therapeutic school. I've worked with a lot of different populations. So just very, very motivated to work on the preventative and early intervention perspective that this project offers. So did I cover it? Is there anything else?
Yeah, no, that's great. That's great. Well, you also went through training through the Arizona Trauma Institute.
Yeah. Which now I'm not having it on the top of my brain. It's the certified functional medical specialist in trauma training. Which is, you know, when we talk about the domains of wellness, a lot of the conversations that we hear our providers talking to families about are the domains of wellness. So providing the families resources that they can use, tangible resources that they can use that day when they leave. So focusing on, you know, getting in touch with nature and movement. So just really trying to work that piece into their treatment plan. In addition to, you know, if they have concrete needs or need referrals, that's part of the interventions also.
I think this, we were talking about this as a group yesterday, that this project and the work that we do is sort of in this space between primary care and mental wellness. And so we're sort of, that's why it's great that we have so many different, we have, you know, pediatricians and doctors as part, and nurses, people who have really been in the healthcare system. And then we have social workers and, you know, and a parent advocate that can really give us different perspectives on everything that's sort of going on in this space. So it is a really diverse group of people and that can give us these opinions and perspectives. So it's great. All right. I don't see any other questions. I will say thank you again. Aldina or Steph, if you want to say anything before we close out.
No, thank you. Thank you so much for joining. We hope to see your application.
I will also, real quick, sorry, someone just posted a question. Have you thought about a national resource list by state? And we can say our family services creates a list for each state, for each participant. So we definitely try to give as many resources as possible to you.
Yep. Absolutely.
Thank you so much.
And if you need specific resources for your practice, that's where your coach can come in. And you can kind of talk with the coach about what those might be, and we can help you with that too. Great. All right. Thanks, Lydia, for jumping in. Thank you so much, everyone, for coming today. We're so excited. We hope you see your application soon. If you have any other questions, you have all of our information here. And like I said at the beginning, this has been recorded. We will send this out plus the slides in about a week in an email. It will also be available on the njap.org/TASIE website. And we can't wait to see your applications. Thank you. Have a good rest of your day.